Oh, Prof Rez isn't here. We have big shoes to fill, but who else with actually massive feet to fill them is Dr. Jas Bajwa. So him and I get to discuss the case today, and I'm so, honestly, Prof Rez was telling me that he's a little bit bummed that he couldn't make it instead of me to discuss with Jazz because Prof Rez and Jazz have a lot in common. They're both incredibly smart, but some of the most emotionally intelligent people I've ever met. But unfortunately, Prof Rez couldn't make it for some good family things. Um, so you're stuck with me, Jazz, and I'm very excited for it. I'm even more grateful that you're able to join because I know how busy you are right now with five new admissions. Maybe in the reverse order of things, I'll hand the mic to you to say hi, and then we can together introduce the awesome crew that is making today happen.
Thanks, Robbie. I agree with you. The only shoes I will fit Reza's seat is literal. So big shoes to fill, definitely on the VMR space. But excited to co-discuss with you, Robbie. You're selling yourself short, and not just your height. But the only complaint I have against you is you never respond to my voice messages. But that's a work in progress. Hopefully, one day you'll start responding them.
4 minutes. Four. You think I'm just gonna sit there like this for 4 minutes? I'm the most restless
You can
emergency.
drive, you can do other things, you can have it in the
Oh,
background.
no, Dr. Bajwa, you're offending me here. If you are talking to me in any way, shape, or form, voice message or not, you have my attention. 100%. And so, yeah, and then I know I could speed it up. I could even translate it into text. I could do many things, but I cannot shake the idea that if Jas is gonna talk at me for 4 minutes, that I'm not gonna pay genuine deep attention to it. So I had just have a roadblock. I don't think we can communicate in that way. You know what? It's no different than me sending you a 4 minute voice note in Arabic. You're just, like it's no, it's no different. It's no different. Anyway, um, I actually, to be honest with you, I started listening to it, but then I had some unexpected events happen this morning that I will fill you in privately with. They're all good. They're all good. But I will respond to your voice message. I promise. But see, we're already getting carried away. Let me ground myself in reality and show a lot of gratitude to the two people who are making this happen today. Zachariah, thank you so much for scribing, and Manaha, thank you for teaching points. Maybe I'll hand the mic to each of you in that order so you all can say hello, and then we can introduce our case presenter.
Hi, everyone. I'm Zachariah. Looking forward to the case, but actually slightly looking more forward to being able to eat in about 5 minutes' time. Almost done.
Amazing. You're almost there. You're almost there. And Manahil?
Hello everyone, I am Minahil, IMG from Pakistan and incoming PGR1 at Corval Health. Yeah, it's very exciting and very excited for today's guest too and you and Jazz discussion.
Manahil, congratulations on the match. I know it culminates many years of hard work for you. Very proud of you and looking forward to your continued growth. Last but not least, we have a returning guest case presenter, the biggest fan of the warm weather. By the way, I love how warmly you're dressed. Baha, welcome back. Tell us what you've been up to since your last case.
Not much, just work. I've actually started swimming again. Uh, Honestly, that's it. Work, swimming, and sleeping. The simple life is the best life.
100%. I'm actually wearing my swim shorts right now because as soon as we're done, I'm gonna try to go for a quick swim before work. So
Let's
really,
go.
I
Let's
know, right?
go.
I absolutely love the pool. But I'm sure we'll dance and have fun together over the next hour. So why don't you just jump right in and we'll hear
Sure.
Jax's wisdom for the first hour.
All right, sure. So today we have a 48-year-old female presenting with a 4-month history of epigastric discomfort, bloating, and postprandial fullness.
Yeah, shall we stop? Do you want us to stop here? Is that what you had
Yes, I will
planned?
stop here. Yes, yes.
Yeah, awesome. I love this stop. Alrighty, Jas, what are you thinking?
Yeah, so I think the first thing that really stands out is the time course, this few months. And we're having postprandial fullness and epigastric discomfort and bloating. And so I feel like I want to ask the patient, like, is it truly bloating or is it distension? But I think, when I think of epigastric tenderness and also postprandial fullness, the first thing that comes to mind is this some type of peptic ulcer disease. But with the bloating aspect, could this be a dyspepsia type of component? But given her age and her gender, I also will be thinking at the gallbladder here too. Typically not epigastric, but it could if there's a gallstone that's now being intermittently obstructed, but now it gets more obstructed, which prompted her to come in. But I think the first thing that would make me initially pause from all of those things I listed is the time course. And I don't want to miss a malignancy in this case, like a gastric malignancy, especially if this is persistent epigastric tenderness, especially if we find out in the next aliquot that she's been losing weight. Or the biggest takeaway from this first sentence is the postprandial fullness and the few months, because that tells me is there some type of mass or some type of thing that's growing in the abdomen, upper abdomen, like the stomach, that is now causing her to eat small amounts of food and get full. And the time course for me is the biggest thing to take away from this first sentence. But in just focusing on the epigastric discomfort, if this was acute or even subacute, I would say this is peptic ulcer disease. This could be gastritis, pancreatitis, even hepatitis, and gallbladder. But the few months and the postprandial fullness is what really captures my attention in the first sentence. But I'd love to know what you think, Robbie.
I'm right there with you. I have nothing to add to your thoughts. I just wanted to take the opportunity to make a broader clinical reasoning point about the value of the time course. And I think whenever somebody has anything but an acute disease, you'll find yourself actually getting much more return on investment by not studying the discomfort that the patient has, but rather studying what functional complications they have as a result of that. And by that is going to be a nebulous statement that's not necessarily clear. So let me try to kind of take you back to what you need to know to understand that clearly. When people come in and seek care, their fire alarm is going off and they are in some sort of discomfort. They're hurting. Our job is to use their discomfort to help us figure out where the problem is so they do not accumulate any dysfunction. And so a very common example is somebody says, "Hi, doctor, my chest hurts." And my job is to make sure that their heart remains in good shape so that it continue to walk, talk, and exercise. That's my job. The problem with acute diseases is that there may not be any dysfunction because the patient has presented so quickly. But if we wait too long for the MI to turn into heart failure, they're going to have dysfunction very soon. The biggest advantage of subacute diseases over acute diseases in terms of problem solving is that more than enough time has accumulated for the patient to have dysfunction. And if you are dealing with a subacute disease that has not accumulated any dysfunction, well, here's the analogy. It's no different than the fire alarm going off, 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 off for weeks, and yet there be no fire. So the problem, therefore, must be with the fire alarm itself. And I think that's exactly what you heard Jas do. He was starting to say, I want to make sure the patient doesn't have distension. I want to make sure that the patient doesn't have weight loss and all sorts of consequences that really have to do with dysfunction of the GI system. So right now we have the patient saying it doesn't feel good in this area. And what we are going to use to make the most progress is, okay, well, have you accumulated any loss of function of that area? And that'll help us a lot. This doesn't apply if she had presented with a few days of these symptoms, because we wouldn't be able to know if enough time is accumulated. So I right there with you. And I think my biggest piece of advice is when a patient presents with anything more than a few days of a disease, look for the dysfunction, and that'll help you make a lot of progress. All right, Bahad, tell us more. What do you have next?
So HPI, she reports nausea, but denies vomiting, hematemesis or melena, She has noticed a gradual decrease in appetite and unintentional weight loss of 3 kilograms over the past 4 months with anorexia. And that's it.
You asked for those questions, Jas. What do you think of them now?
Yeah, so I think this is definitely helpful. Now, I think the next question I would be posing myself here is this loss of 3 kilos in 4 months. To be honest with you, it could be explained by a decreased PO intake in itself. It doesn't have to necessarily mean. So when we think of weight loss, where it's a simple equation, calories out is greater than calories in. And the calories out component is either there's something that is increasing the amount we consume calories, so either high metabolic syndromes like hyperthyroidism, or there's a bacteria like an indolent bacteria or a malignancy that is consuming those calories. And now the other part of the equation is calories in. So we just got told that her appetite has been gradually decreasing, and she's had 3 kilo weight loss with no mention of other B symptoms. So in real life, I would definitely still be concerned of a malignancy, but honestly, the 3 kilos is a good amount, but I think it could be explained by her decreased appetite in general. And I still wouldn't really move the needle too far away from like peptic ulcer disease. That could, in itself, if there's an ulcer there causing chronic epigastric pain, postprandial fullness, maybe there is a component of pain from the postprandialness that is making her eat less and avoid food and causing the weight loss. The other aspect of it is there some type of gastroparesis or gastric outlet obstruction? That's where the past medical history is going to be very key. Does she have diabetes or some other type of thing that make me concerned for gastroparesis or gastric outlet obstruction? But something that goes away against that, she's not really having emesis. It's more like bloating and nausea, which like for me makes it more seem like gastric outlet obstruction. And like I said earlier, I still think in real time, I would still be concerned for gastric malignancy, but probably first quantify a little bit further, like, is it more than 3 kilos? And do you feel you're eating enough calories to maintain somewhat of weight and you feel like your weight loss is more disproportionate? I think in this situation, I would clarify a little bit of history, get the past medical history, but I think exam will also be very important in this situation. Robbie?
Yeah, I think that's such a superb analysis. I have absolutely nothing to add. Literally nothing left on the table. Really, really good job. But yeah, tell us more.
Sure. So this patient works at the city hall. She denies alcohol use or smoking or NSAIDs use, and she has no history of liver disease or any gastrointestinal bleeding. But there's family history of her mother had peptic ulcer disease and was diagnosed with the H. pylori infection. And that will be it for this quote.
Awesome. I guess not too much to add here. I feel like it's nice to see that she doesn't have a past medical history. She is a little bit on the younger aspect of the spectrum, so that kind of checks out. But then honestly, it does raise my concern a little bit. It's like, okay, so she's clearly going through something here that she finally comes to the hospital. I'm assuming this is the hospital setting to get care. So that would raise my social history bucket a little bit higher. It's like, why is this lady coming in now? And she's had a clean bill of health before this. I'm not familiar with family history being strongly associated with peptic ulcer disease, but H. pylori has been known. If a family member has H. pylori, there's been some studies that link that together, say that you're also at increased risk for H. pylori. So that does increase the PUD bucket a little bit higher for me, and secondary from H. pylori. But other than that, I don't have much else to add. I think the lack of smoking and alcohol does reduce the risk of gastroadenocarcinoma by a little bit. But if she eats a lot of barbecue or other meats that are smoked, it's still a risk factor for her. But other than that, not much to add, Robbie.
You know, I think that it's I like the way Baha is presenting because it goes to show you like how much actual progress do you make until you examine this patient. And I think with Jas's conversation, you're seeing that the answer is very little. You really need to see how much devastation is this disease laying upon this patient. I think it is an opportunity just to emphasize how cool H. pylori is, both in how it was discovered, which you should totally look up, but its pathology was. Were you going to say something, Jas?
You like froze for like a good like 30 seconds. Was that me or you?
I don't know. Let's ask Baha. Did you hear me or
N-
no?
Uh, I heard you. I think it was you. Yeah.
Oh, I'm
Aha,
sorry.
Dr.
Okay.
Bajwa.
No,
Sorry.
I don't mean it like no.
Oh, my fellow swimmer would never abandon me like that.
True, true.
Yeah, you know, I think the story of the discovery of H. pylori is really cool, and ultimately it involves a fascinating story of somebody who actually ingested the bug to prove it caused disease. And I think doubting whether H. pylori existed is a very fair thing because to invoke an infection that actually takes over the highly acidic stomach is something really a counter to our knowledge. And it's true that most of the impact of H. pylori is on the stomach, though I think we all have to recognize that most patients have asymptomatic disease. So if you actually screen populations, you'll see that the incidence of seropositivity of H. pylori is much higher than the number of patients who have the disease. But if you are going to have the disease, you'll see that the illness script for H. pylori and symptoms is very broad, from asymptomatic, as we talked, to dyspepsia, to peptic ulcer disease, to a malignancy. And the malignancy is both adenocarcinoma and a maltoma, or a mucosal associated lymphoid neoplasm. It's also interesting just to note that H. pylori can have some paraneoplastic, quote unquote, phenomenon, with idiopathic thrombocytopenia being the most tightly associated. So it's a fascinating bug, a fascinating story, and some really cool associated symptoms. Who knows if any of this spiel is relevant to this case, but yeah, why don't you give us your next doc?
Sure. So she appears slightly fatigued, but not in acute distress. Her vital signs, her BP is 130 over 185, heart rate 88, respiratory rate 16. She is afebrile, and saturation is 98%. Abdominal exam, she has mild tenderness in the epigastric region on palpation, with no rebound tenderness, no garden, and no rigidity. The liver and spleen are not palpable. And the skin, there's no jaundice, no spider angiomas or palmar erythema. Extremities, no edema, no clubbing. And the neurological exam is normal, no asterixis or focal deficit. And that will be it for this aliquot.
Excellent. I think we can make some progress here. I think the physical exam shows mild tenderness to epigastric. So I feel like and with no rebound regarding. So I don't know how specific these tests are, but no rebound regarding makes me feel like at least this point in time in a patient that does not have any chronic steroid use, that the chances of a perforation or something that needs to be done before thought about is less likely. And she looks well appearing, which is always good. It tells me that we have time to think about this. And then it also tells me that she's not jaundiced and there's not a liver component or stigmata from here, especially with no spider angiomas or pulmonary erythema on exam. The fatigue aspect makes me wonder if she, we don't mention, there's no mentioning of her looking pale, but the fatigue does make me wonder, is it all from the anorexia, because she's not having enough intake, or is there an anemia component? I think that's where the CBC and CBC would be helpful. But no edema tells me that, and then no abdominal distension tells me that this was not her physical abdomen wasn't getting bigger, and it was more of a bloating and postprandial fullness that she was feeling, which really makes me worried more about the gastric outlet obstruction, at least from this exam. The mild tenderness to palpation could be from the pancreas as well, but that's all I have to add in this aliquot. This is reassuring that the vitals are reassuring. Robbie?
I love the observation about the fatigue. I think that's really key. I think as you're trying to say, like, what do I do next for this patient? Based on the fact that the exam is giving you subtle clues that there's something going on, but it's not raging. I'll do something a little unusual, maybe ask my friend Julia. So Julia, you're going to be an intern very, very soon. And I'm really curious, just based on your reflex thoughts, what kinds of labs are you hoping to get in this patient? What do you think would help you make progress?
Love your invitation here, Ravi. I'm definitely looking for an inflammation component in the background, so the WBC count would be very interesting. But besides, also I want to know if there's been any bleeding in the background. So definitely getting yeah, hemoglobin.
Excellent. Yeah.
I think these are my the major concerns I have.
Yeah.
Also, I would be interested in an LDH, to be honest, because there can
Yeah.
be some lymphoma associated to it as well. So focusing on, sorry.
Yeah, beautiful. I know I say this to all of you because most of you will be taking care of a patient like this. And I'm not looking at the chat directly, but occasionally the messages come so quickly that it pops up in the on open box. And I saw David said something really funny. He's like, do you send this, if this patient came to the ER, do you send them to the hospital with Reza or to the clinic with Austin? And I think that the truth is there's no reason for this patient to go to the hospital right now or even the ER right now. And so most of these cases I see that are referred to clinic, patients who come into clinic. And I really, really appreciate the opportunity to reflect on what labs you would actually really get in a patient like this. And I can't tell you how often that patients like this either don't get any labs and just get empiric PPI and get discharged. And so you have to ask yourself, like, how do I know which patient to actually just get labs in who has epigastric pain? And I think my suggestion is if you are in a resource decent setting, most patients with epigastric pain should get labs because the number of times you'll be surprised by hepatitis or pancreatitis, or maybe not pancreatitis with subacute, but a liver involvement, deep anemia, or other things that aren't just benign peptic ulcer disease is reasonable enough to do so. But I'll tell you that many, many patients just get empiric PPI and or H. pylori testing and get close follow-up. And I think that that's an okay strategy as long as you have close interval follow-up. And here the counter argument to that is that the patient has accumulated some consequences, that she's lost weight and she appears fatigued. So I think most people would cross the threshold for diagnostic testing in this patient. But if you change the fatigue and you make her comfortable and you say she has no weight loss, I think many people would say, you know, try PPI, we'll see how this goes. You haven't accumulated any dysfunction yet. But in the reality of this case, I think that I have one piece of advice for you all, which is most people would get a CBC, a comprehensive renal and liver metabolic panel, a lipase, and call it a day. I think the importance of iron studies in this patient cannot be underemphasized. The idea being that before you get anemic, you first get iron deficient. And many, many patients will first have a low ferritin before they have a low hemoglobin. So even if you tell me that this patient's hemoglobin is normal, what I'm anxiously awaiting for is actually the more proximal diagnosis, which is, are they iron deficient? And because an otherwise young and healthy person like this may maintain a normal hemoglobin despite very advanced iron deficiency, but the presence of iron deficiency would really change your management in this situation. So I think one small, take this opportunity to emphasize the value of iron tests in a patient with epigastric pain. Under your category of hemoglobin, add that test too. It can make a huge difference in a patient's course, and it can help you diagnose gastric cancer, gastric lymphoma well before overt anemia develops. But one thing that comes up for these patients that I'd love for Jas's advice on is H. pylori testing, because you have a family history here, you have epigastric syndrome. What advice do you have about folks about how to test for H. pylori?
Being a non-GI doc, I guess I
Yeah.
would start off with the stool antigen. It's, I think, pretty reliable from what I remember. The only thing is they should not be on a PPI.
Beautiful.
That can sometimes cause false negatives, I believe. I vaguely remember there are some other factors that can interfere with them with that testing, but usually if they're on a PPI, you have to hold it for six-ish weeks, I believe. But That's the main thing. I would start off with the stool antigen. I think
Yeah,
she's,
beautiful.
yeah. So
Yeah, I think that the two options are to do an antibody testing or to do direct testing for H. pylori. The antibody testing is a test that's marred by the fact that all patients who have been exposed are seropositive, and it does not capture the patients who've been exposed and cleared. So many more patients have H. pylori antibodies who have cleared it than who actually have the disease. So the best tests for H. pylori are really either the stool antigen or the urea breath test, with the stool antigen being much more commonly used. And so I think in this situation, since she's not on a PPI, you might give her a stool antigen to take home. And if you are being very patient-centered, there's no reason not to start her on a PPI for her relief. So if I were seeing this patient in clinic, I would get the labs that we just mentioned. I would get a stool antigen, and then I would give her a PPI to take after she submits the sample for the stool, just in case this is just pretty bad peptic disease and she feels better after the PPI. All right, Baha, tell us more. What do you have next?
That was amazing. Jas, that was a great observation about the fatigue, whether it was from anorexia or anemia. And I will actually just give you the labs. So her hemoglobin, I will start with the iron studies after this. So her hemoglobin was 10.5, her MCV was 78, and her MCH was 24. As for the iron studies, her serum iron was low, TIBC was high, and serum ferritin was low. I want you guys to discuss this, and then I will give you the other labs.
awesome. So I think we now have a middle-aged female with subacute onset of weight loss, postprandial fullness, fatigue on exam, and history, and now confirming iron deficiency anemia. So I think when you phrase it like that, I think, you have to consider a EGD, or even start off with the CT scan to see if there's anything over it. But if a CT scan is normal, and I've seen this half of the times where you get a CT scan, there's nothing there, you get an EGD and there's a mass. So I feel like this is a lady that I would start off with the CT just based off these labs alone. Because now like Robbie mentioned in the previous aliquot, that this is evidence of iron deficiency anemia, and we have to rule out malignancy. She's 48, so I would imagine she's not having periods. So if she was a little bit younger, you could have made an argument that if she's having a history of heavy periods, that the iron deficiency may not be true and unrelated. But in this situation with the weight loss and the postprandial fullness, I would take this very seriously. And this still could be H. pylori associated peptic ulcer disease, or a secondary complication from H. pylori, like multiple lymphoma, like Robbie mentioned 2 aliquots ago. But regardless, I think we need more studies, and I would start off with the CT. And the reason I'm saying starting off with the CT is every culture is different, but most GI docs will probably want to say, let's get a CT first to see is there evidence of pancreatitis or something like that, an obstruction, gastric outlet obstruction. But I think this lady's heading towards an EGD. So I'd love to know what you're thinking, Robbie.
Yeah, I think that's a great analysis. I really appreciate you being transparent about the fact that different GI doctors want different things. I think the probability of an intraluminal process causing low-grade bleeding is so high in this patient that ultimately, no matter what other test you get, you need to look on the inside of the lumen. And the question is, what's the value of looking outside the lumen? And I think the main value is to really diagnose something that is extending beyond the lumen into the intraperitoneal space. And the probability of that with very minimal epigastric tenderness is low. So to be transparent, if I were this patient suffering from this condition, I think that anything short of an EGD would be a misstep. And so I think, sure, a CAT scan may decorate the picture, but it's not the core test that you need. And I think if you see something on CAT scan, your heart will drop for this patient. If you don't see anything on CAT scan, you shouldn't slack. That's really, I think, ultimately what it comes down to for me. I do have another very minor, but I think important piece of advice, which is whenever somebody has iron deficiency anemia in the context of this symptom complex, we do proceed very quickly toward assuming there's blood loss and getting an endoscopy. But I think there's one important condition to keep in your back pocket that you can really accelerate the patient's care for, and that's doing celiac serologies. The prevalence of celiac disease is 1% of the general population. And so when you have anybody with epigastric discomfort and iron deficiency, I think assuming that you assuming that there's blood loss and getting ED is very wise, but you can expedite the workup for celiac disease. So I think another small thing you can do is sending an IgA level here and sending celiac serologies, but I think an upper endoscopy is going to be very, very key. All right, Mahan, tell us more. What do you have next?
Okay, sure. So the liver function tests were normal. I think I will start with the imaging. Yeah, abdominal ultrasound, it was normal. But we did an endoscopy. It revealed erythematous gastric mucosa with a mosaic-like pattern. So this was consistent with the gastropathy. And also there were non-bleeding esophageal varices, grade 1, in the distal esophagus. An H. pylori stool antigen was done. It was positive. And also there were, okay, I will leave this after. I'll stop here.
That's a very interesting aliquot. So, we don't see any evidence of a gastric mass, which is good, reassuring. The erythematous gastric mucosa with mucosic pattern in the setting of H. pylori being positive is actually very interesting. So, I mean, H. pylori most commonly actually can cause like H. pylori associated gastritis. But the varices caught me a little bit off guard because there's no history of cirrhosis here on lab evidence, on clinical, and I think the ultrasound showed it was normal too, so there's no hepatomegaly. So then I'm trying to see if that's somehow connected. I don't personally know about anything of varices being connected with H. pylori, but I do believe H. pylori can lead to portal hypertensive gastropathy, and I'm wondering if that could be the case. And the other thing I'm thinking is the mosaic pattern is, I remember learning that MALT can have like a patchy distribution, and I would still be concerned for a MALT lymphoma secondary to H. pylori. And I didn't see any evidence of like, a watermelon stomach for me to be concerned for GAVE. So I think that's less likely. But I think right now what's going higher on my list is this like this mosaic pattern similar to like a MALT lymphoma? And then the second thing is this portal hypertensive gastropathy secondary to possible H. pylori? But and the secondary to H. pylori gastritis. But I would love to get your help here, Robbie.
This is the value of an EGD, is like ultimately you're sometimes shocked as what you find, and I think I'm nothing but shocked that the patient has esophageal varices, which are essentially diagnostic of portal hypertension. And so now you're like, well, I'm solving a problem that I didn't expect to solve, which is why does this patient have portal hypertension? And I think you now ask yourself, like, okay, is there any other evidence for portal hypertension? And that's where I think the platelet count would be helpful. So Baha, do you happen to remember what the platelets were on the CBC?
They were
Okay.
normal.
They were normal. Okay, that's very interesting because about 80% of 80 to 90% of patients with portal hypertension have low platelets, but that's not 100%. And then Baha, was that on the ultrasound, was there any evidence of splenic enlargement or any ascites? No spleen, no ascites.
No spleen, no ascites.
Interesting. So you're if you're trying to build a case for patients with portal hypertension, you're getting this interesting combination where there's the varices in the esophagus seem to be dilated, but the spleen doesn't care, nor does the fluid in the belly, nor does the platelet count. So how you reconcile those things, I think, is very, very interesting. And I'd also be curious if there was a dilated portal vein or something on the ultrasound. So here's where I would be at. I would be like, okay, esophageal varices are really very specific for portal hypertension. And so should I proceed assuming this patient has portal hypertension or not? And I think the morbidity of esophageal varices is too high that I think we should assume the patient has portal hypertension. But you might say, well, are there any causes that are prioritized in a patient who doesn't have ascites, who doesn't have a big spleen? And that's where a splenic vein thrombosis causing isolated splenic vein thrombosis or compression or something just restricted to the splenic vein can cause disproportionate esophageal varices. So I think how you can proceed in this case is to say, I definitely need to biopsy the stomach to make sure there isn't any H. pylori related complication. But now I think we have to pivot our workup to saying, why is the portal vein under high pressure? And to really reinforce that, I think that I think it'd be difficult. You might make sure that the ultrasound was done with Doppler. You might have to get a CAT scan to see if the portal vein is in fact dilated and the ultrasound is insensitive. But it'd be really curious how you pivot now. But I think we're essentially saying that we're worried that this patient has portal hypertension. And I think getting more evidence for that by imaging the portal vein either with Doppler or with a CAT scan or with anything is probably what I would do next. And of course, now that you have H. pylori, you probably should treat it and to see where that takes you.
Robbie, I'm just curious, would inflammation from let's say the H. pylori leading to gastritis leading to an isolated splenic vein thrombosis, would that explain this or no? I don't know the answer to that. I'm just asking.
Yeah, I think that's probably an explanation that is that I think many people would find plausible, but I think you'd have to park it at the endpoint of your diagnostic hypotheses for sure. Yeah, I think there's enough ambiguity in how this case is playing out that you probably would be open to a unusual combination of things. Because if you really truly have portal hypertension that is slam dunk, you often either at least have a big spleen or ascites. And the fact that we don't have any of them is unusual enough that I would be open to a kind of unconventional answer. But before parking it at unconventional, I'd be like, is this just a sneaky way that a common disease is manifesting? All right, but Mike, to you.
Sure, that was amazing. So the Doppler ultrasound showed no evidence of portal hypertension, and the biopsies taken from the antrum, they had confirmed the H. pylori infection. And that is it for this aliquot.
I just want to say, Bahad, your short aliquots is very unique, and I feel like it leads to a real lifetime events of how you get results. So definitely keeping me on my toes. So I think the Doppler ultrasound showing no evidence of portal hypertension is interesting, and I feel like I would feel like this might be related to now non-cirrhotic or pre-sinusoidal portal hypertension, and I ask myself why, right? The only strong signal we're getting so far is H. pylori positive gastritis and iron deficiency anemia secondary to maybe these non-bleeding esophageal varices. I don't see any sequela of schistosomiasis. There was no peripheral eosinophilia. I don't know where this patient is, but I would imagine they're not in a high geographical risk factor. But I feel like, to Robbie's point earlier is, being this all attributed to H. pylori should be a diagnosis of exclusion. You don't have to have eosinophilia. I would ask her more social history questions if I feel like schistosomiasis might be up there. But from the history that we have so far, I wouldn't have it very high on my list. But I'll be very honest with you, other than those two things, and then basically H. pylori associated gastritis leading to some of these mosaic mucosal pattern that may have led to this non-cirrhotic portal hypertension is the only thing that comes to my mind. But in real life, I would eradicate the H. pylori, correct the iron deficiency, and then ask her to see a GI doc in 6 to 8 weeks to get a repeat endoscopy and see if this is improved. Because right now there's really no strong signal of anything that would make it have have a momentum in one way. The only thing that's coming up is this H. pylori associated chronic gastritis. But Rabih, I would love your help here.
Baha, you're messing with us, man. Something's not adding up. He's messing with us. Something's not
No,
adding
I
up.
am.
Let me tell you why. Something's not adding up.
Okay.
The esophageal vein is so hypertensive, it's popping into the lumen. And so I expect there to be something else that's hypertensive. And so I'm trying to figure out, like, okay, where is the blockage? And the spleen is not blocked. The platelets aren't low. There's no portal hypertension anywhere. There's no ascites. So I'm like, are you fooling with me? And so I think fundamentally, when you have an abnormality that is serious, you have to take it seriously. But when it starts to just be completely like nonsensical, you have to step back and say, am I being fooled here? So you ask yourself, how do I know this person has esophageal varices? Well, the endoscopist saw it. And my question is, are the endoscopists perfect at diagnosing esophageal varices? I would never ask that question outside this case because of the fact there's no portal hypertension, there's normal platelets, there's normal spleen size. So is this just a simple old case of H. pylori gastritis with something fooling us? And so what I would do next is really just have a conversation with the person who did the scope and be like, are you sure these are varices? We found no portal hypertension. The platelets are normal. There's no ascites. There's no splenomegaly. There's no cirrhosis. And there's nothing else. So is this leading us in a different direction? Or there is a very, very, very proximal obstruction right after those varices, i.e. at the splenic vein. So I think what I would do next is probably talk to the endoscopist and or get a CAT scan to really try to see, is there something next to the esophagus that is looking like varices? But something's not adding up here. We're not able to coalesce the problem except understanding clearly this patient has H. pylori related gastritis, treat her, see what happens. What about those varices? Are they really varices? That's where I'm at, Jas. I think Baha is tricking us somehow.
No, that's exactly the thinking. So she was diagnosed with gastropathy secondary to H. pylori infection, and we are awaiting for a CAT scan. But meanwhile, even though there is very few literature on this, it is believed that the vascular changes came from the chronic inflammation rather than the portal hypertension itself, because there is no evidence of liver disease or portal hypertension on imaging.
Wow.
Yeah.
So wow, that's really, really cool. Do you know,
Yeah.
Baha, do you remember were the gastric varices thought to be big or small? Oh, you said grade 1.
Grade 1, yeah, and
One.
they're non-bleeding, so they're very small.
Interesting. Wow, thank you. I love this case. This is outpatient
Yeah.
case. Just like your last one.
Outpatient, yeah.
Yeah, very, very interesting. Jas, what are your thoughts?
I think this is like I've only read about cases where H. pylori can lead to these type of vascular changes, but I've never seen it. And I think your reflection is still very accurate. And like I learned a lot from the fact that, was this truly varices and not like some type of vascular ectasias that could have happened secondary to the inflammation from the H. pylori. I think vascular ectasia as a differential diagnosis in this case, I think is a very great teaching point that you shared. But yeah, I think even for like, this is bread and butter. Like you see this, even though like maybe the endoscopy finding may not be bread and butter, but H. pylori leading to postprandial fullness and IDA, iron deficiency anemia in a 48-year-old female. I think there was a lot of teaching pearls, and I really love the case. Thank you for preparing it, Baha.
I really enjoyed it.
You're most welcome, Jas.
I really enjoyed it too, Baha. I think you made the hospitalist Jas discuss an outpatient case, but you know that he is a family medicine doctor fully trained in taking care of these patients. I just want to really genuinely thank you for bringing now two outpatient cases of bread and butter diagnoses. And I hope that anyone listening to this is inspired to showcase their bread and butter cases, because VMR is too biased towards things that most of you will not see. And Baha, you're helping us by teaching us how to approach a very common concern, epigastric pain, how to approach the diagnosis of iron deficiency, how to approach analysis of H. pylori testing, how to approach analysis of an EGD, and some really cool clinical reasoning principles about when some things don't add up, what do you do? And so a lot of gratitude to you to really keeping VMR very real. And I'd love to pass the mic to you to share what you learned while you were. What are the things that you want to emphasize for people listening?
Just to correct you, Robbie, it wasn't gastric, it was esophageal varices, not gastric.
Ah, okay. Thank you.
And yeah, this was a self-paced case that it was like building up, and it just showed that sometimes in medicine we don't always have an answer, especially in this case. So it is believed, like I said, that the gastropathy, the chronic inflammation, is the reason that caused the vascular changes and that had caused the esophageal varices. And it was interesting to see a case with someone who has non-bleeding esophageal varices and not have portal hypertension. So, yeah.
Amazing. Thank you so much. Really appreciate it. And we'll hand the mic now to Manahil to summarize the learning. Oh, Manahil, I think you're muted.
Okay, thank you, Baha, for presenting this case and wonderful discussion by Ravi and Jas. At first, we studied about like approach to postprandial fullness. For DDs, for that was like peptic ulcer disease, functional dyspepsia, based on its age and gender, it can be cholelithiasis and malignancy. Then we have to characterize the discomfort, whether it is acute or subacute. So basically in acute, there is like no dysfunction at the present, but in the subacute cases, there may be an underlying dysfunction. So it is up to us, like we have to figure out that dysfunction and address that. Then this patient have a weight loss. So in that case, calories out is greater than the calories in. So calories out are greater due to any malignancy, hypermetabolic state of the body, or maybe due to any chronic infection. Then we have the calories in that is less. So that can be like due to postprandial pain or any small bowel obstruction, which has affecting the patient appetite. Then we have discussed like a wonderful story about H. pylori. And we discuss about the GI manifestations and extraintestinal association. So in GI manifestation, we can have dyspepsia, peptic ulcer disease, and malignancy. That can be of two types, adenocarcinoma and mild. And in extraintestinal association, we have paraneoplastic phenomena and idiopathic thrombocytopenia. In H. pylori, we have the two things, whether we have to do the labs or empiric treatment. So labs are always preferred because it will help us to address any underlying anemia if the patient is bleeding or any hepatitis. But empiric treatment is like preferred in the high prevalence population with follow-up. Testing for the H. pylori, that will be of two types, that is serologic antibody testing, and we have to do stool antigen or urea blood test. In antibody testing, like we will just get detect the exposure. We cannot differentiate that whether it is like a past infection or its patient still have that infection. But if we do the antigen or urea blood test, it will detect active infection and it will help in the diagnosis and to confirm the eradication. Then in this case, like we will like to have two imaging, that is CT scan and the EGD. CT scan so that we can evaluate the structures beyond the lumen. That can be extramural pathology or any retroperitoneal involvement. And with EGD, we can have the direct visualization of the lumen. So we will be able to detect any mucosal lesions like ulcer, gastritis, and malignancy. And second thing that we can do a biopsy sampling. And like the last point, I will end at the presence of the esophageal varices are mostly, at most of the time, are indicative of the portal hypertension, but that was not the case today. And thank you very much.
Absolutely superb. You really, gosh, both the organization that you have on the whiteboard, Manahil, and how clearly you narrated it. You clearly had a very, very great grasp of all learning in this case. Thank you. Jas, final word to you, my friend, just like Prof. Rez would do it.
Thank
Thank you, Baha.
It was a lot of fun. Thanks all.
Thank you. Baha, come more
Yeah,
often.
thank you.
Don't go another 2 months without another really cool case. We really enjoyed our cases.
I'm
And-
enjoying the simple life.
Keep it up, my friend. Have a great day, okay?
You too, guys. Bye
Thank you,
bye.
Zachariah. Thank you, Manahil. Bye.